Modern health feels stable because it is automated. Most people do not consciously manage their survival variables. Water arrives pressurized and treated. Waste disappears. Refrigeration preserves insulin and biologics. Pharmacies refill prescriptions on schedule. Hospitals exist as escalation points. Oxygen, antibiotics, imaging, sterile technique, and advanced monitoring are assumed to be available within reach. That is not personal resilience. That is systemic continuity. The dominant myth of collapse centers on violence, firearms, civil unrest, dramatic confrontation. While violence can occur during instability, historical disaster mortality consistently shows that the majority of excess deaths and infrastructure failure arise from environmental exposure, infection, chronic disease destabilization, and preventable procedural errors. Most deaths are not cinematic. They are cumulative. Nothing is left vague. The objective is not fear. It is clarity. The architecture of modern survival to understand what kills people after infrastructure failure. You must first understand what keeps them alive during stability. Modern survival depends on continuous electricity, potable water treatment, sewage removal, cold chain preservation, pharmaceutical manufacturing, transportation logistics, professional labor availability, waste management, environmental climate control. These are not luxuries. They are biological stabilizers. Electricity preserves insulin. Water treatment prevents fecal-oral transmission. Waste removal prevents vector proliferation. Climate control prevents heat stroke and hypothermia. Pharmaceutical supply prevents chronic destabilization. Remove one variable and risk increases. Remove several and risk multiplies. The human body compensates temporarily when systems falter. Compensation has limits. Infrastructure failure becomes lethal when biological compensation is exceeded. System degradation model infrastructure failure does not immediately produce catastrophe. It produces degradation. Stored food remains safe. Pharmacies may still open. The primary risk in this phase is not biological collapse. It is behavioral delay. Families assume restoration. They postpone adaptation. They do not inventory medications. They do not ration water. They use unsafe heating methods. They move in darkness without preparation. The first 72 hours are when preventable fatal errors begin. Carbon monoxide exposure during outages is a prime example. The CDC repeatedly documents preventable CO deaths during power interruptions due to indoor generator or fuel-burning appliance misuse. Symptoms: headache, nausea, confusion are frequently misinterpreted as fatigue or stress. Opening parenthesis cdc.gov, early collapse mortality is procedural. Phase 2 supply strain, day 3 to 10. Cold chain stability declines. Fuel shortages impair logistics. Pharmacies ration or close. Hospitals saturate. Water advisories appear. Biologically, stress hormones increase. Cortisol rises. Adrenaline remains elevated. Chronic disease destabilization begins subtly. Blood pressure creeps upward. Blood glucose fluctuates. Sleep becomes fragmented. Anxiety increases. Appetite irregularities appear. Stress-induced sympathetic activation increases cardiac workload. Sleep deprivation impairs immune function and insulin sensitivity. Mild dehydration compounds blood viscosity and blood pressure. The body is still compensating, but it is under load. Phase 3, sanitation breakdown, week 2 to 4. Waste accumulates. Improvised toilets appear. Stored water containers become vulnerable to contamination. Trash attracts insects and rodents. This is when infectious disease risk accelerates. Fecal-oral transmission increases. Diarrheal illness spreads. Skin infections become common. Respiratory irritation rises due to particulate exposure and poor ventilation. The immune system, already strained by stress and sleep disruption, becomes less effective. Minor wounds now become clinically significant. Phase 4, chronic destabilization, month 1 plus. Medication stocks deplete. Insulin cold chain fails. Dialysis access disappears. Nutritional adequacy declines. Cardiovascular risk rises sharply. Diabetic crises increase. Renal and endocrine failure accelerate. Psychological exhaustion deepens. Behavioral discipline weakens. Hygiene slips. At this stage, mortality accelerates quietly. Collapse mortality is not explosive. It is erosive. The primary killers in infrastructure failure. The dominant causes of death during prolonged infrastructure failure are Dehydration and electrolyte imbalance, diarrheal disease. Respiratory infections and environmental exposure. Sepsis from untreated wounds. Cardiovascular events amplified by stress and medication interruption. Diabetic crises, carbon monoxide poisoning, heat stroke, and hypothermia, accidental injury. Psychological collapse leading to neglect. Each will be examined in detail. Plasma osmolality, electrolyte concentration, and blood volume are controlled by renal filtration, antidiuretic hormone ADA, and the renin-angiotensin-aldosterone system, RAS. When water intake drops or fluid losses rise, compensation begins. ADH increases water reabsorption. Aldosterone promotes sodium retention. Heart rate increases to maintain perfusion. Peripheral vasoconstriction preserves central blood flow. These mechanisms are temporary. At approximately 2% body water loss, cognitive function declines measurably. Attention, short-term memory, and risk perception degrade. At higher losses, coordination falters. Electrolyte imbalances can provoke cardiac arrhythmias. In collapse environments, dehydration occurs due to reduced water intake from contamination fear, increased sweating and heat without climate control, diarrhea from sanitation breakdown, fever from infection, increased physical exertion. Dehydration does not initially feel dangerous. It feels like fatigue, irritability, and headache. That misinterpretation leads to underreaction. In elderly individuals, thirst perception is blunted. In children, fluid loss represents a greater proportion of total body mass and progresses faster. Dehydration is often the first variable in mortality stacking. Diarrheal disease. Amplifier of mortality, diarrheal illness in stable environments is inconvenient. In infrastructure failure, it is lethal primarily due to dehydration. Fecal-oral transmission pathways increase when hand-washing discipline declines. Clean water access is uncertain. Food preparation surfaces are contaminated. Waste is improperly managed. Children require close contact care. WHO data consistently identifies diarrheal disease as a major cause of preventable mortality globally, particularly where sanitation infrastructure is compromised. The physiology is direct. Fluid loss reduces plasma volume. Sodium and potassium imbalances impair neuromuscular and cardiac function. Renal perfusion decreases. Weakness increases fall risk. Dehydration worsens any concurrent illness. If sanitation discipline fails within a household, diarrheal illness can spread rapidly. Prevention is not optional. It is survival. Respiratory illness and environmental exposure crowding increases respiratory transmission. Poor ventilation traps particulates and pathogens. Improvised heating introduces combustion byproducts. Respiratory compromise and collapse arises from viral spread in confined spaces, mold growth from dampness, smoke exposure from indoor cooking, dust accumulation, sleep deprivation weakening immunity. Respiratory illness increases oxygen demand while reducing oxygen exchange efficiency. Asthma exacerbations increase, COPD destabilizes. Pneumonia becomes more dangerous without antibiotics and oxygen. Respiratory deaths and collapse are rarely immediate. They are progressive. The risk compounds when sleep deprivation persists, nutrition declines, air quality remains poor. Sepsis. The consequence of neglected infection. Skin is a barrier, breach it, and bacteria gain access. In stable systems, wounds are cleaned, dressed, and monitored. Antibiotics are accessible if needed. In degraded systems, hands may be contaminated. Water may be unsafe. Dressings may be scarce. Monitoring may be inconsistent. Professional escalation may be unavailable. Localized infection can progress to cellulitis. If untreated, systemic inflammatory response may follow. Sepsis represents a dysregulated host response to infection, leading to organ dysfunction. Without advanced medical intervention, mortality risk rises dramatically. The lesson is simple but non-negotiable. Prevent wound contamination. Monitor aggressively. Escalate early when possible. Sepsis begins small. Cardiovascular events, stress, dehydration, and medication interruption. Cardiovascular disease remains a leading cause of death even in stable society. Collapse increases risk through multiple pathways. Stress hormones elevate blood pressure. Sleep deprivation increases sympathetic tone. Dehydration thickens blood. Electrolyte imbalance disrupts cardiac rhythm. Physical exertion increases cardiac workload. Medication interruption destabilizes control. Abrupt discontinuation of certain medications, such as beta blockers, can provoke rebound hypertension and tachycardia. Heat stress further increases cardiovascular strain. In collapse conditions, middle-aged and elderly adults performing unfamiliar physical labor in hot environments are at high risk. Cardiovascular mortality in disaster settings often rises in the weeks following infrastructure disruption. Diabetic crisis diabetes management is infrastructure dependent. Insulin requires controlled storage. Monitoring supplies must be available. Diet consistency matters. FDA guidance emphasizes refrigeration for insulin storage and warns against exposure to high temperatures. Without stable insulin access, hyperglycemia develops. Increased urination, dehydration, fatigue, impaired wound healing, increased infection susceptibility. In severe cases, diabetic ketoacidosis develops, characterized by metabolic acidosis and systemic instability. Hypoglycemia, conversely, can occur if insulin dosing does not match reduced food intake. Children with type 1 diabetes are among the most vulnerable populations in prolonged infrastructure failure. Diabetes is not just a glucose problem. It is a hydration, infection, and cardiovascular multiplier. Carbon monoxide. Immediate and preventable carbon monoxide binds hemoglobin with high affinity, reducing oxygen delivery. Symptoms resemble fatigue or viral illness. This misinterpretation delays evacuation. CDC guidance is explicit regarding generator placement and indoor fuel-burning hazards. CO deaths are almost entirely preventable with disciplined behavior. Heat stroke and hypothermia, thermoregulation failure is lethal. Heat stroke is characterized by high body temperature and central nervous system dysfunction. Hypothermia is defined by a core temperature below 95 degrees Fahrenheit and impaired cognitive and motor function. Both conditions escalate rapidly in vulnerable populations. Climate control loss transforms environmental exposure into medical emergency. Accidental injury, darkness, fatigue, dehydration, and unfamiliar tasks increase fall and burn risk. A fracture in collapse is not just an injury. It is a mobility limitation that increases pneumonia risk, skin breakdown, and dependence. Preventing injury prevents cascade. Psychological collapse, chronic stress impairs immunity, sleep, glucose control, and cardiovascular stability. Behavioral degradation leads to hygiene lapses and medication non-adherence. Psychological stability is the behavioral engine of prevention. Without discipline, prevention fails. Risk stacking, no single variable kills most people. Layering does. Example: dehydration gives cognitive impairment, gives unsafe heating, gives CO exposure. Or, mild hypertension plus stress plus dehydration plus heat gives stroke. Or, minor wound plus poor sanitation plus sleep deprivation gives infection, gives sepsis. Collapse medicine is cascade prevention. Civilian limits. This book operates within civilian scope. You can prevent contamination, monitor symptoms, stabilize early risk, enforce discipline, manage environment. You cannot replace ICU-level care, perform advanced surgery safely, manufacture pharmaceuticals. Recognizing limits prevents lethal overconfidence. Foundation principle: collapse medicine is not about heroics. It is about removing preventable mortality variables. Water discipline, sanitation rigor, infection vigilance, medication continuity planning, thermal safety, carbon monoxide avoidance. Psychological stability: understand what kills people, then prevent it.